prematurity. And we are lucky to have her today on our neonatal Pathshala platform. And she is being covering a lot, many areas of Gujarat in which we had previously unable to do ROP, which is a very important thing because it can lead to, we all know that it can lead to blindness and later on many complications. So I think she is a blessing to whole of Gujarat that we are able to all the babies get all the babies ROP screening. So thank you so much, ma'am, for joining us on for this session. For her introduction and other coordination, I would request Dr. Vishal Goel, who is our project in charge for Neonatal Pathshala series. Over to you, Dr. Vishal.
Thank you, Kunal. So I welcome all of you. And as we know, the ROP is like a most important thing who are dealing with the preterm baby and especially high risk baby in the NSU. And I think it is like if you see the last decade, I think there is not only the blindness but also like a medical legal issue is also happen previously in last 10 years in India. So there's a very important topic has to be discussed. And for that, we do have a renowned faculty from Gujarat, Dr. Rekha Singhal. And she's a director and consultant vitreoretinal surgeon at Drishti Netralaya Hospital, Surat. She's a director of Drishti ROP program for ROP screening across the South Gujarat since 2019 and expanded to Saurashtra and the North Maharashtra. She has more than 9 years experience of the senior vitreoretinal surgeon at SVNM Surat. She did her MS ophthalmology from BJ Medical College. She's a gold medalist and she's a long-term vitreoretinal fellowship from 2014 to 58 from Narayan Rudralaya, Bangalore. FECO in 2015 and received the Natraranjan Award for the best paper in vitreoretinal at AIOC 2015. So she is a multiple paper and poster presentation and also received a lots of awards from across the India. She is one of the few surgeons in India performing the complex ROP surgery and dedicated clinician with the vast experience of the treating more than 800 ROPs babies and more than 2,500 adult retinal surgeries and currently presented at multiple state and the national podium. So I welcome Dr. Rekha and over to
Thank you, sir. Thank you, NNF Gujarat, for giving me the opportunity to speak on this platform on the topic which is very dear to my heart. I would like to thank the team of NNF Gujarat, the President, Dr. Nirmal, sir, Dr. Secretary, Dr. Kunal, sir, and Dr. Vishal, sir, the project in charge, and all the esteemed panelists on being part of this podium. So, I'll be talking about all about the ROP. So, next slide, please. So the most important thing before we discuss anything about ROP is we need to answer this question: why the blindness happening from the ROP is not acceptable. So there are three major reasons here which are there. Next, please. So the most important reason is, as Dr. Kunal sir and Dr. Vishal said, it is a blindness for the lifetime. So if someone gets blind because of a disease happening in age of 50 or 60, the blindness duration is hardly for 10, 20 or 30 years. But here, once the child becomes blind, he becomes blind for the lifetime, and which is equal to death. Why I say it is equal to death? Because 80% of the milestones which are happening in a child is because of the visual stimulation, and the rest 20% is contributed by the other senses. So the vision plays a very important role in the growth of a child. Second, once a child becomes blind, it creates a big economic loss to the country, and the blindness burden, which is calculated, is if one baby goes blind, it is equal to 59 lakh rupees to the society. And the third, next please. And the third, the most important factor for us being a pediatrician or into a medical fraternity is the medical legal things which happens due to the medical legal negligence in ROP if a child becomes blind. Next slide, please, Shreyanshi. So this was a landmark judgment which was given by the Supreme Court in 2015, which allowed the compensation of 1.8 CR to a government medical college in Chennai, where there was this much of a compulsion along with the restriction of few of the pediatricians, superintendent, admin people, and ophthalmologists there. So, next slide. So the way to prevent this is to do a timely screening and a quality treatment. And I can assure you all, by doing this, we can make this disease preventable 100% of cases. And if we do this, we won't see any babies coming blind with the ROP. Next, please. So when I talk it is 100% preventable, but why we are still seeing the babies with the blindnesses, there are three major barriers there. The first, the most important, is the lack of awareness in public and to the pediatrician regarding the screening guidelines, when to screen and how to screen. And second is the lack of the trained ophthalmologist or the retina surgeons across to diagnose the ROP in rural and semi-urban area. And third is the lack of a timely and the quality treatment there. So what we do ahead? Next, please. So before we discuss about this, we need to understand the anatomy of eye, how the eye works. So this is a model of the eye where we see a cornea in the front, we have the lens in the center, and we have the retina behind. So what we are talking about, the disease is retinopathy of prematurity. So it is a disease which affects the retina part of the eye. Next slide, please. And once we see the retina in full, this. Next slide. Yeah. So here we see the full retina from aura to aura. So this whole of the retina is divided into the three zones. So this is very important for us to understand these zones. Why? The central part, the centermost blue circle is the two disc diameter area from the central part of the, if you put a circle from the center part of the macula and make a radius double the distance from the disc, it makes a zone 1. Why this part is so important? The center point, what we are seeing, I can't put my cursor here and show you. The center reflects what you are seeing is the area fovea or the macula. Now this part of the retina is most important for our fine vision. Whatever we see, whatever, how we recognize the face, how we read, all that vision come from this part. So this zone is very important. Next, the nasal, once we draw a circle from disc to the nasal part of ora serrata, that much area is the zone 3, and the rest of the area which is temporal left is zone, in between is the zone 2, and the rest of the area which is left temporal is the zone 3. Now, the vessels inside the worm start developing from the disc and slowly they reach towards the ora serrata. We'll learn further how they develop and what age group, how much of the vessel development happens. Next slide. So this was the standard classification in the ETROP. So this is a diagram which shows us the blood vessels start forming intrauterine from the optic nerve head at 16 weeks of gestation, and it reaches the nasal ora serrata by 32 weeks, that is 8 months, and reaches the temporal ora serrata by 40 weeks, that is a term baby. So once we have a term baby, full term baby, the vessels are completely mature and there is no disease called as a ROP there. But once the baby born, before this, there will be some immaturity in the retina itself. Next slide. So coming to the pathogens, I want everyone to learn this by heart. How does the ROP develops? So once the baby is inside the womb of a mother, there the environment itself is little hypoxic. So the saturation of oxygen in the umbilical blood is very less compared to the routine oxygen what we have in a routine body. So because of that, there is a hypoxic environment inside the womb of a mother, and therefore that hypoxic environment allows the development of the VEGF molecules, that is vascular endothelial growth factor, which is responsible for growth of the vessels further. Now, once a baby born prematurely, now the baby is outside, then comes a phase 1. So what is that phase 1? Because the ambient air outside has a more oxygen saturation compared to which was there inside the womb, or if the baby is premature, he has some problem with the lungs, and we need to give the oxygen from outside in the form of CPAP or ventilator or anything. The amount of oxygen which is available is very high compared to which was there inside the womb, and that creates a hyperoxic environment. This is very important to understand. So in initial part of the time, initial 2 to 4 weeks post birth, there is a hyperoxic environment which creates a vasoattenuation. So the vessels will constrict because of hyperoxia, and the growth of the vessels will stop there at that point of time. Now, with time, after 2 to 4 weeks, usually the baby becomes stabilized and you wean off the baby from the oxygen. And the second most important part, even if you have not given any oxygen from outside, there will be development of the layer of the retina, that is photoreceptor layer. That photoreceptor layer has the maximum need of oxygen, and that creates a relative hypoxic environment now, and that will lead to release of more of the VEGF molecule inside the eye, and that leads to vasoproliferation. Now, whether the baby develops a disease or not will depend upon how much of the VEGF is released there. If it is abnormally high, it will lead to formation of abnormal blood vessels in the form of ROP. And if it is in the normal amount, it will allow the vessels to grow forward, and the vessels will grow from zone 1 to zone 2, zone 2 to zone 3. So this part is very important to understand. Next slide, please. So this is how a immature retina will look like, and in the ICROP3 they have changed the term the immature retina to incomplete vascularization. So here we can see the optic nerve head, from there the vessels are starting, that is moving forward, and it has stopped there. Beyond that there is no vessels. So this is an immature retina or incomplete vascularization in zone 1. Next slide. So once there is the development of a disease, there it is divided into the 5 stages. We'll be talking about that. The stage 1 is called as a demarcation line. So the word line itself says it is a two-dimensional structure. We can see a whitish line which is formed between the vascular and the avascular retina, which is demarcated with a black arrow there. Next slide. So in stage 2, there is a formation of this line which was there, which was a two-dimensional structure within the retina. Now that has moved upward and has a volume within it. Okay, so this is called as a ridge, where the line becomes thickens and have a volume and comes within the vitreous cavity now. Next, please. Next comes the stage 3, which is called as the extraretinal fibrovascular proliferation. Once you know the term itself, it will explain you extraretinal. Now the vessels, fibrovascular. So the fibrous tissue and the vascular tissue which should be within the retina, within the plane of the retina, is now growing within the ridge itself and is coming out of the retina. So it is called an extraretinal fibrovascular proliferation. This is stage 3. So this is the abnormal neovascularization which is happening there. And this is the stage where we would like to treat the baby. Next slide. So next comes the stage 4, which is usually a detachment. So now the baby has a detachment, is divided into 2 parts, stage 4A and 4B. So the difference between the two is in 4A, the macula is attached. Why we have given importance to this? Because the prognosis of a baby depends a lot whether the macula is on or not. Because that is the place which is responsible for our reading, writing, vision. And in 4B, you have a detachment of macula also. Next, please. And in stage 5, we divide into 3 parts, that is 5A, 5B, 5C. Here there's a total retinal detachment. Total retinal detachment means none part of the retina is attached right now. Everything is detached. So in 5A, when we see it clinically, we can see the optic nerve head there. In 5B, we can't see the optic nerve head. It is a funnel-like configuration. And in 5C, you usually have an anterior segment changes in the form of synechia, cataract, and corneal opacity. So these images, what we are seeing of stage 5 are the babies from Gujarat itself. So we need to understand we are still dealing with the babies who reaches to stage 5. Next, please. So next comes the important parameter to diagnose whether the baby needs a treatment or not is the plus. Okay. So what is plus? So normally the vessels inside the retina, what you are seeing are not dilated. So because there is avascular retina, there is a need of a blood supply, and there is abnormal vascularization. So to overcome that demand, the vessels will dilate and will become tortuous to allow a more flow of blood there in the area of a disease. Okay, so in plus disease, you have a dilatation of the posterior pole vessels along with the tortuosity. Now in ICROP3, they have defined, initially it was just no plus or plus. Now they have defined a spectrum where we define it as no plus, pre plus, and plus disease. Next, please. The next term, which is very important, which you would be seeing day in, day out because of survival of more preterm and more smaller babies, is the APROP, which has now been shifted to EROP in ICROP 3. So, what is that? Initially, it was called as aggressive postural ROP because this disease was used to limit into zone 1. Now, we are seeing this disease even in zone 2 and zone 3. So, what is different in this disease? What we had talked right now was stage 1, stage 2, stage 3, stage 4, where we're seeing the disease like there's a formation of line, then there is a rush, then there is abnormal vascularization, extraretinal. Here, what we are seeing is there is a formation of flat neovascularization which is sitting inside the retina. And here there is no formation of stage 1, stage 2, stage 3. Directly, this neovascularization, which is formed within the retina, will contract and lead to stage 4 or stage 5. So you won't be seeing the classical stages here, but this is a different physical form of a disease which present in a different way. So when you see a baby with AROP, you usually treat them with the injections. We'll come into the treatment. This will come into the treatment part. Next, please. So coming to the incidence, it was projected like almost 18,000 infants go blind every year in the India. And mind you, retina diseases are responsible for one-fifth of those cases, and 80% of the retinal causes is the ROP for the blindness. In India, we have more large and immature babies, more than 1500 grammars, those who develop a severe ROP, and more than 6.3% of more than 2 kg babies develop a treatment required ROP. Next, please. So, coming to the burden, what we are facing right now in India is it was, next slide. It was projected in 2020 by WHO that India is harboring the maximum number of preterm births in the world. So, we have around 30 lakh babies who are born every year, who are born too soon in each year. We don't need to screen all those babies. It's a big burden which is there to screen. Okay. Next slide, please. So, whom to screen? That is the one most important thing what we need to learn as a pediatrician, as a fellow there. So, the screening guidelines, they are very easy. That is 1, 2, 3, 4. That means any baby. Next slide, please, Shriyanshi. So, any baby who is born at less than 34 weeks at birth needs to be screened. Or when the gestational age data is not available, any baby who is born with birth weight less than 2 kg needs to be screened. So, if the baby is more than 34 weaker, if there is different risk factors like the sepsis, failure to gain weight, transfusion, RDS, small for gestational age, patent ductus arteriosus, or any other risk factor for which the neonatologist feel this baby have a stormy course, that baby should be screened once at least. Okay, next slide. सो दिस इज वन ऑफ माय फेवरेट लाइन, अगर आप अधूरे महीने पे जन्मे हुए बेबी के आंखों का समय पर इलाज नहीं कराते तो आप आरओपी है. Okay, this is very true in the sense because the term itself is ROP and it is ROP once you don't do that. Next slide, please. So once we know whom to screen, then comes the question when to screen these babies. Okay, so because we are dealing directly with these babies, we need to learn by heart these rules when to screen. So the best practice is to screen between the 3rd to 4th week of life, irrespective of gestational age. But if the baby is less than 1200 grammar at birth, or babies is born less than 28 weeks of gestation, then we need to screen, do the first screening within 2nd to 3rd week of life. And we need to understand any sick baby is more likely to develop an ROP. So we should not be delaying the screening just because the baby is sick. And there is another guideline which is given by the RBSK now and also the government of India is that we should be doing the first screening preferably before the discharge of a baby from the NICU, even if the baby is 5 days old. Okay, next slide. So there is another paper which was published based on, this slide is on how to screen. So how do we dilate these babies? Because once we need to see the retina, we need to dilate the pupil to look onto the retina. We can't see the retina without dilating. So how to dilate these babies? So the drops which are commercially available is tropicamide phenylephrine, where the phenylephrine is 5%. Okay, we cannot use that drops. We need to dilute this with distilled water in 1:1 configuration, so that to get a phenylephrine of 2.5%, because if we have a 5% phenylephrine, that can create a blanching and create a systemic side effect like what is seen in the photograph here. What, how you dilate? You put a one drop in each eye 2 to 3 times, 15 to 20 minutes apart, and within 30 to 45 minutes, the pupil will become fully dilated, and then you can see the retina. If you see after even after putting the three drops, you are not able to see the fully dilating pupil, please stop. Let the ophthalmologist have a look on the baby and find out whether the disease is more progressive. The patient has if the patient has an NVI, that is neovascularization of iris, it will not allow the pupil to dilate. It means the baby in a more worse situation. Okay, so don't go on putting up the drops there if you don't find a dilatation of pupil. Let an expert see and comment, and then go ahead. Next, please. So how do we examine the baby? So there are two methods of examination. The first is by a vitreoretina surgeon by wearing the indirect on the head and take a 20D lens in the hand. We put up a alpha speculum which is specifically designed for the for these preemie babies, and you need a depressor to depress the eye and to look into the ora serrata, because you need to look to the end of the eye till the ora to diagnose whether the baby is fully vascularized or not. Okay, before we start up examination, we always want the room to be warm to prevent the chances of hypothermia there. Okay, and if the parents are inside, they sometimes feel why you have put some clip inside the eye and some iron rod was used to move the eye, and they feel why this all was done. So we need to teach them, we need to make them realize this is the most important part to diagnose the disease on time and to diagnose the disease properly there. Next, please. Now, with very limited, there was a study which was done by the Indian ROP Society, where they found hardly 200 retina surgeons are comfortable doing the screening, and less than 150 are comfortable doing the treatment. So once we have to cover the burden of 30 lakh babies who are born too soon, how do we reach each one of them? So imaging is the way which is way forward, and Dr. Anand Manikar from Bangalore, Narayan Netralaya, he was the first to start the telemedicine program for ROP in India in 2008. So he started the KidDrop program. So imaging is a way, because it is a way of an objective evidence where you can show the parents, you can do a better counseling to the parents. Okay, your baby had this much of a mature retina in the last week. Now it has developed this much. Now it has developed this much. If the disease is developing, you can show them on the images. Ki here is the ridge. Now the abnormal vascularization has happened. Now there is a bleeding. Now we need to treat them. Okay, it is also an excellent tool for documenting things and can help you in medical legal purpose, and it is an excellent tool for academic purpose to teach the fellows how to diagnose the disease, how the disease behaves. And definitely it has made a way for us to reach each of the rural area in each part of the country, because it can be done by the paramedics, where we train them how to capture the images of the retina, and they become an expert to even diagnose, counsel, and advise the treatment to these babies and the parents. Next, please. So by using the telemedicine model, we are covering whole of the South Gujarat right now. We have reached till the Dang, which is the tribal belt. And then we were getting the babies from the Saurashtra area, and we have started screening. A team goes by a train to Junagadh, covers almost 550 kilometers by train. This is a pilot project, and we are trying to expand our services to rest of the areas where the screening is not available. So do reach to me if someone needs screening at any place of the Gujarats for their reference. Next slide, please. So next come the schedule and the documentation. One most important point for allowing the screening is you need to fix a day and a fixed time of each week for the screening. It should never be done on the ad hoc basis. What are the NICUs we adopt? We always make it a point. We make a 1 day fix for each NICU and a fixed time where the babies and the parents know when to come for the follow-up. And the sister inside the NICU know when the team will be coming. They don't have to call and confirm, okay, aap kab aayenge. Okay, so this is very important. We have a fixed schedule of screening in each NICU. There should be always a list of the babies which should be printed or written on a board there, ki which baby needs screening on which date. So you need to teach your sisters there, all the sisters which we are covering, the NICUs which we are covering. The sisters know once the baby is admitted into NICU, they will put up on the board the screening will be required on this day. Okay, so this is how you put up a list of the babies so that we don't miss any baby who requires the screening. We need to make a documentation according to ICROP guidelines, which I will be showing in the next slide. And after documentation, you need to counsel the parents. You need to give them a card. You need to give them a definitive date when they have to come up for the next visit. do remember this is a medical legal document. You need to mention there are many medical legal cases which has happened because there is no mention of a definitive date when they have to come up. There is no mention of the proper findings, how to document it. So all this is very important medical legally. Okay. And as a ophthalmologist, we need to always inform our pediatrician or neonatologist in charge about the status of the baby, how the baby is doing. Because many times, once we see the images, once we see the retina, we come to know, okay, this baby is anemic, this baby has got a transfusion, this baby might have some stomach cause because the disease has progressed suddenly. Okay, so seeing the retina is one place where we can see the blood vessels directly, and we can see what is happening inside the body. Next slide. So this is a file which we give to the patient, where in the top on the left side, we write all the demographics of the patient, all the risk factors there. In the center are the images, just representative images to counsel the parents regarding the disease, how the eye forms and how the disease behaves, all that. And on the left side is the documentation, where I would have written the date of each of the visit, the gestational age in each visit, diagnosis according to the ICROP classification. The next follow-up date is mentioned. It is not only weeks there. I always write a date there and then a signature. So this is a document which you need to give to the parents so that they know when they have to come. And if the baby is going to some another doctor, they have full of the documentation, how the disease is behaving, how the child is doing. Okay. Next, please. So this is a paper which I was talking about, where they did a study of 329 infants in 2 NICUs, and they enrolled each baby. They did the screening of each baby before discharge from the NICU, even if the baby was 5 days old. Okay. So what they found out, next slide, please. What they could conclude from this was key the enrollment into the ROP program was more when you enroll the baby before getting discharged from the NICU, because the parents get an exposure. Okay, there is something called as the eye checkup, the ROP checkup, which is required, because once they go to the home, they forget any eye checkup is required till they don't come back. Okay, so this allowed them to have a more enrollment, and the number of sessions, screening sessions which were required were less compared to was same as the standard guidelines. Next slide, please. Next slide, please. Okay, coming to the treatment part. So there are two treatment modalities what we prefer. That is the either the laser or the anti-VEGF injection. And the second modality is the surgical intervention, which we don't want any baby to go. Okay, so our motive is always to diagnose the baby on time and to treat them according to only with the laser and anti-VEGF. So when to treat? So any baby who has a stage 3 without plus disease in zone 1, or any stage with plus disease in zone 1, needs to be treated. Okay, in zone 2, any baby with stage 2 or stage 3 with plus disease needs to be treated, or any baby with the AROP or APROP needs to be treated. So how do we decide whether to do a laser or whether to give an anti-VEGF injection? Next slide, please. So laser therapy is a gold standard treatment. It is since years together, decades together, we are doing the laser therapy for the ROP. The advantage of laser is it is once done properly is done for the lifetime. You have a finite follow-up. Once you do a complete laser, you see baby after 2 weeks, then 1 month, and then you see every 3 monthly only for the refraction. You know this baby won't have a risk of any retinal detachment in the future, and the baby will see for the lifetime. But there are some risk factors, some disadvantages with this technique. The first is the once you do in topical anesthesia, it is a painful procedure. The baby will have pain during the procedure. We have the ways how to combat that pain. That is, we give a sucrose pellets inside the mouth, 24% sucrose or 10% dextrose. Okay, or you can do under anesthesia also if the surgeon treating is not comfortable doing the laser in a topical anesthesia. The second important is the refractive error. The baby can has very high chances of developing a myopia. Okay, and the amount of area which is lasered usually will create a permanent scotoma. So there will be a restricted visual fields in a long term. And the fourth most important factor is the long learning curve. Doing the laser in a moving child is a very difficult. It's a very difficult art to master, because if you don't complete a laser properly, there will be a recurrence. Okay. Next slide. So this is how we do a laser. We can see on the first slide, we have a aura and we have a ridge behind. I start my laser from the aura. I demarcate the aura there. Then I fill up the area in between. You can see the white dots there, and then you complete the whole of the area. Next slide. This is how these are the fresh laser burns. And once you have completed the laser, And you see a baby 3 weeks post laser. Next slide, please. You can see the scars developing. These are the developed scars, and then once this is done, after 2 to 3 weeks, you see the neovascularization has disappeared. The plus has come down. So this is how the disease has regressed completely. Next slide. And the laser is also affecting the babies when you have an early traction. So this is a baby who has developed a traction. There you can see a red arrow demarcating the ridge itself has lifted. Now it is going towards a 4A now. So we do a laser where we do a laser anterior to the ridge, we do laser posterior to the ridge, and after 1 week, once this ridge disappears, you fill up the gap in between. So laser is helpful even in preventing, allowing this baby to regress from early stage 4A to a completely vascularized retina. Next slide. Next come the indication of anti-VEGF injection, which is very popular nowadays for all the retina surgeons and for the pediatricians. So anti-VEGF injection is indicated in the babies who have an NVI, that is neovascularization of iris. So once we have an NVI, we cannot dilate the pupil, and in those eyes, we don't have a view to laser the avascular retina. So in the babies who have an NVI, we don't have a visualization for doing a laser. We can use anti-VEGF therapy as a primary modality of treatment. And second, for the babies who have a disease in zone 1 or zone 2 posterior, or the babies who have a AROP, they are under treatment. The first line of treatment is anti-VEGF injections. Okay. The third indication is we give the anti-VEGF injections for decreasing the neovascularization before surgery in stage 4A and stage 4B. Okay. Next slide. So the advantage of anti-VEGF injection is it is easier to use. You get a very rapid response. It's a very small procedure. Okay, and once the disease regress, the vessels will start moving forward, and you have a better vascularization of the retina. The disease can recur, of course, but you get a better visual fields in the future and a better visual acuity. Next slide. Seeing to these advantages, there are multiple disadvantages which we need to take care of, and that is the reason we don't do anti-VEGF injection as a routine course in all the babies. So the disadvantages which are there are, next slide. So this is a slide which shows the two type of anti-VEGF molecules which are there into the market, which every one of the pediatrician is very eager to understand, why Avastin or why Eccentrix or Razumab. So the Avastin is a bevacizumab molecule which has a longer half-life and has a lower recurrence rate. The cost of this is less, but the only problem here is it is not FDA approved. But I will tell you, this is a favorite drug of all ROP surgeons to be used for the ROP disease here. Okay, while the ranibizumab, which was given the FDA approval in 2019, has a shorter half life, has a higher recurrence rate. So, what does that do? Higher recurrence rate. So, if we have given an injection to the baby who has a disease in zone 1, okay, the effect of the drug remains hardly for a month, and the vessels would have reached only to the zone 2 posterior, and the recurrence will happen. And once the recurrence happen, we usually try to do the laser. So, the area which we have to ablate is more in ranibizumab compared to bevacizumab. So, our first line of drug always remains as bevacizumab there. Next, please. So the problem here with the anti-VEGF injection is the recurrence rate are high to 30 to 60% in most of the babies. And usually you need to see these every week post injection till you don't see a recurrence or you find a complete vascularization happening there. Okay. Multiple debates happen on anti-VEGF, which anti-VEGF injection. As I said, whether Avastin or a ranibizumab, there is a medical legal problem there with the use of the Avastin there. Okay, whether to give it unilateral, whether to give it bilateral, whether to give in NIC or whether to give in OT. Okay, all those are the multiple debatable things with the anti-VEGF injections there in the ROP. Next slide. So there was a paper which we have published recently regarding the use of bilateral anti-VEGF injection, because we usually don't give anti-VEGF injection bilaterally in the adults. That is given in very few cases. But in babies, because this is a bilateral disease, we do give the injections bilaterally. So this was a paper which was a multi-centric retrospective study, a collaborative study pan India, including the 16 centers, and where we documented the highest number of babies across the world which have been injected bilaterally, and the safety of same was presented in this paper. Next slide. So, while coming to some questions, ROP does not develop in the babies who have not been given the oxygen. How many of you agree with it? Audience, participants, any would like to answer? Back slide, please. Shreyanshi, go to the previous slide. So we need to understand that any baby who is not given oxygen can still develop an ROP, because the most important factor there is a prematurity itself. As I told you, once the baby is outside the womb prematurely, even the ambient oxygen creates a hyperoxic environment there. Okay, so it is very important. The second myth which is there is you can't examine or do a laser to a sick baby. We need to understand we can examine each baby even on the ventilator, even on within the walls, and we can screen them there as I'm screening there within this. Okay, and we can treat these babies within the NICU itself. Next slide. Is ROP present at birth? Anyone would like to answer? No, it is not a disease with which the baby is born. It is a disease which is acquired later on, which we need to understand, and therefore we need to screen the babies later on, not at the birth itself. Next slide. What is the most important factor for development of a treatable ROP? Oxygen, sepsis, anemia, NAC. So the most important factor is the prematurity itself. Rest all are the associated factors which may help in progression of the disease there. Next slide. So this I want someone to answer. What are the screening guidelines for ROP? I hope I'm able to teach you this. Anyone from the participants would like to answer this question? Anyone? Okay, so I will repeat my words. We need to screen any baby who is born less than 2 kg at birth or is born at less than 34 weeks at birth. Okay, and we need to screen the babies within 1 month, that is known as 30 din roshni ke, that is between third to fourth week of life. Or any baby who is born less than 1200 grammar or less than 28 week at the birth, the first screening needs to be done within second to third week. Okay, next slide. Thank you. We need to spread the awareness for this disease by putting up the posters in the NICU and the waiting areas, and can have a small testimonials or videos regarding the method of examination, the importance of the screening there. Next slide. Thank you. I'm open to the questions now. Over to Kunal sir.
Yeah, thank you so much, ma'am, for the excellent talk. Actually, there were answers for your questions. Dr. Mansukh has written less than 34 weeks, then Dr. Shah 3 to 4 weeks before discharge, Dr. Vishal in low birth weight babies, and all those answers are there in the chat box.
Okay, great, great, great.
Yes, ma'am. So, uh, thank you so much, ma'am. Actually, we are a little short of time. If anybody has any questions, they can post it in the chat box, or you can even directly unmute yourself also.
Yeah. Any questions from the panelists there? Kunal sir, from your side?
Ma'am, sometimes we see that post ROP, post examination, the incidence of desaturation increases in preterm baby. So can it be due to the medication or the drops which we put, or because of the examination itself? Sometimes there are high blood pressure, or what can.
Uh, One thing is the drops itself can create. So the ideal method is once you put up the drops, you need to wipe up the extra drops from the cheek, because the skin is very thin for the absorption of the drops. Second,
Okay.
you can press over the punctum to decrease the absorption, systemic absorption of that drop. into the systemic circulation. That is one point. Second
Okay.
is during the examination, if it is a beginner, they can take time to screen the babies. You put up a anesthesia, topical anesthesia, paraquin drops there, and you have to be little quick in your examination. Or you can give a sucrose, 24% sucrose to the baby to reduce the pain during the examination.
Okay, ma'am. One more question, ma'am. Recently, I had attended an conference in Hippocrates, in which the one of the USA center, Iowa, they are what they are doing is initially, not initially, but later on, once they see that the baby is showing D line and all, they are giving oxygen intentionally to prevent the progression to treatable ROP. So, then they have done a trial also, stop ROP trial.
Yeah, but that was
Yeah.
stopped actually. That is no more followed. That is a
Okay.
trial which was there, but that is no more followed. Doesn't
Okay.
have a rule.
Okay. So actually, they are still practicing that.
Yeah.
And in many of the babies, even they are discharging, if they are discharging it a little early or so, like after 34 weeks or so. And if
Mhm.
still there are any D lines or there, they are discharging with home-based oxygen also in those babies. So,
We don't follow this in
okay,
Indian
ma'am. Okay.
scenario at all.
Okay.
Yeah. And I don't feel that makes a difference. Because here the major role is there of the avascular retina, the amount of avascular retina which is there, the golden hour, which was the first hour post birth, which makes a lot of difference into the outcome of a disease there.
Okay.
Yeah.
Uh, Done, ma'am. Since there are no further questions, and even that we are a little short of time. Thank you so much, ma'am, for the
I will just
excellent.
put up my phone number here. If anyone has any questions, they can message me directly and ask the questions at my number.
Sure, ma'am. Yeah, everybody can note down ma'am's number.
Yeah.
Yeah. So thank you so much, ma'am. It was a very lucid and an uh, in-depth presentation. So it was very easily by pictures and everything you had shown that it was very easy to understand. Uh, Dr. Vishal had to leave because of an emergency delivery call he had to attend. So
Okay.
thank you so much, ma'am.
Thank
It
you.
was a really nice presentation, and this will be online on YouTube also. So later on, also we have participants who have joined you on YouTube also, and later on also they can see this presentation. If you want, I will
I'm
share
just
you the
really
link later.
sorry for hassle which has happened in the start.
Oh, that's fine, ma'am. It
Yeah.
happens sometime. Uh, so
Thank
thank
you.
you.
Thanks
Uh,
a lot for the opportunity, sir.
Thank you so much, sir.
And
Thank you so
thank you,
much, ma'am.
ClearNet,
Thank you,
for the
Shriyanshi.
seamless experience. Thank you, all the delegates, for their participation. Uh, since there are no further questions, over to you, Shriyanshi.
Thank you, sir. Thank you so much, everyone, for giving us the opportunity to host the session. So, with this, we are concluding the session over here for today, and we hope to have you again. Thank you so much. Have a good day
Thank
to all
you.
of you.
Okay, bye.